So as we think about this whole rationale of combining a next generation IMiD like pomalidomide with a proteasome inhibitor, it's important to go further into that. As I've mentioned, for just biochemical progression, you can think about a relatively limited exposure, such as bortezomib every 2 weeks or ixazomib weekly or something along those lines. Having said that, if you wanted to be more aggressive and the relapse was more worrisome, I think it's very appropriate to consider carfilzomib. The carfilzomib pomalidomide combination is highly active, generally very well tolerated, but it does require the day 1, 2, 8, 9, 15, 16 administration of carfilzomib every month, and that obviously is an investment for the patient. Having said that, the potency and activity of this combination is, in my experience, particularly encouraging and particularly promising, and so it's a very rational thing to do. It's also generally very well tolerated, although it has to be said, just as one worries about neurotoxicity with bortezomib, we always have the concern with carfilzomib of the uncommon but real vascular toxicity that can be seen, be it hypertension, thromboembolic disease, pulmonary hypertension, renal dysfunction, and sometimes cardiac issues as well. Fortunately, these side effects are not common, so that's the good news. And the really good news as well is that, of course, carfilzomib is not neurotoxic, but it's important to bear that in mind when we're making these choices. What is very fair to say is that pomalidomide, as an IMiD that's the most potent that we have to date, has a side effect profile that's generally very well tolerated, and actually, in my experience, my patients have found that after prior lenalidomide exposure, some of them actually find pomalidomide even easier than they did when they were on actually lenalidomide by comparison. Having said that, what I have seen with pomalidomide is you have to be aware that there is some neurotoxicity associated with its use, and sometimes fatigue, as well as also cytopenias, such as thrombocytopenia. So one has to be aware of that. But generally speaking, in my experience, pomalidomide has been an extremely good partner with proteasome inhibitors in this setting. As we think about carfilzomib and pomalidomide in a more aggressive relapse, say this lady had more rapid progression, what would we expect? I think what's very encouraging from data published by colleagues such as Dr. Jatin Shah from the MD Anderson, showing the combination of carfilzomib and pomalidomide is a very high quality and rate of response, approaching 75 to 80%. It's also worth mentioning that with the combination of pomalidomide and bortezomib, we also see very encouraging results with very similar high rates of response, not only with the twice-weekly schedule of bortezomib, but also with the weekly schedule as well. So a variety of studies have shown the potency of this combination platform. I should mention that with the use of ixazomib and pomalidomide, my colleague Peter Voorhees has presented data on that, showing that to be very active as well. But I think certainly the most mature information comes from the carfilzomib pomalidomide experience from Dr. Shah, and I think it's very encouraging. I think also, as I mentioned, we now have obviously phase 3 trials ongoing with pomalidomide, bortezomib, and dexamethasone that will also give us further information about the use of this platform in early relapse. My own impression from my own use of carfilzomib and pomalidomide together is it's generally well tolerated, excellent neurotoxicity profile, and again, fatigue can be a challenge, as can sometimes cytopenias, but generally speaking, it's a well-tolerated regimen. As I mentioned before, there is obviously always the concern about vascular toxicity with carfilzomib, so I'm careful in selecting patients because patients who have hypertension or cardiac history, I'm particularly cautious with regarding carfilzomib use. Similarly, patients with significant renal dysfunction I'm careful with because pomalidomide clearly in patients with renal dysfunction is quite safe. Carfilzomib certainly can be used, but again, one has to be careful because certainly the data suggest, and my own clinical experience has been, that there can sometimes be a renal signal with carfilzomib use that one has to be aware of. So as we think about toxicities for this patient, obviously she's very ambulatory, she's fit, she's well, she's working full time, so anything we want to use is designed to minimize that. So I would suggest that pomalidomide as an oral regimen that could be used in her case is very reasonable. Substituting it for lenalidomide, there's a very reasonable chance she will respond nicely to it. And then there's the platform for adding additional agents to it if needed, if her response to pomalidomide use is in any way suboptimal.